which is titled the case-based discussion for our resident going for exam. And to anchor this section is Dr. Nsese Udene, who is a consultant anesthetist with University of Uyo Teaching Hospital, Uyo, Akwa Ibom State. Thank you, as I hand you over to Dr. Nsese Udene.
Thank you very much, sir. Good evening, and thank you, my NSA, for the opportunity to anchor this program today. Good evening, my elders, my senior colleagues, and all the candidates. I welcome you once again to this webinar series today. Please, a few ground rules will be led so that we can be guided as we begin this webinar series today. Please, if you are not speaking, try and mute your devices. If you are to speak, apart from the candidate who will be identified by the facilitator to speak, when it's time for comments, you please raise your hand. You be patient enough to be recognized to make your comments or ask questions. And please, there shouldn't be any noise from your background when you are speaking. So please be sure you are in a quiet environment so we can all hear you very well. Thank you very much. Please permit me to introduce to us the facilitator for today. And he's no other person than Dr. Muyiwa Rotimi, MBBS, DA, FWAX. He's a consultant anesthetist and critical care physician, a coordinator. He's the coordinator of the ICU services in the Lagos University Teaching Hospital, Idi-Araba. Please, you are welcome, sir, and I hand over the platform to you. Thank you.
Thank you very much, Madam Moderator, Dr. Nsese. I want to thank the organizers of this case-based discussion, the Education Committee of NSA, for a good job well done, and also to thank them for the opportunity given to me this evening. So I welcome everyone to this case-based discussion, which is specifically targeted to assist candidates preparing for the Part 1 exam or diploma exam or membership exam. So the way it goes is this: those that have indicated interest should kindly signify for us to identify them that they are at this webinar, so they can raise their electronic hand. So that's one. Then two, we have questions 1 to 20. So once you are recognized, you can pick any question from 1 to 20, and the questions will be, the question picked will be read out to you. I'll try and read it like twice so that you can get the questions. Then if you have your writing materials beside you, that will be of help, so that at least you can take down 1 or 2 things. Then the third aspect is that you will be given 6 minutes to respond to the question. So you have 6 minutes, and when it's 4 minutes, the moderator will alert you or remind you that you have 2 more minutes. So you have 6 minutes to respond to the questions, and we have like 3 to 4 minutes of contributions and taking of comments. So we recognize all our senior colleagues, they present at this meeting, so they too can be called upon, and also they can feel free to respond to the questions after the candidates must have attempted the questions. I hope this is clear to everyone. Thank you. So do we have those that have indicated interest to, here, so that they can, they just indicate, okay, fine. I can see Benjamin Ame. Benjamin Ame, you can unmute, please. What number? So you have numbers 1 to 20. Just pick a number. I'll read it out. then you respond in 6 minutes.
Okay, thank you very much, Chief. Number 2.
Number 2. You have a 25-year-old man who was said to have lost consciousness at work near your hospital facility, was rushed to accident and emergency unit. A 25-year-old man who was said to have lost consciousness at work near your hospital facility and was rushed to accident and emergency unit. A, outline your management, 20 marks. B, list possible differential diagnosis. Outline your management, 20 marks. List possible differential diagnosis, 5 marks. Your time starts now.
Okay, thank you very much. I will approach this question. Is a medical emergency. ABC with ABC resuscitations. I will take quick history. What happened to the man, where the event occurs, and prior to the onset, if the man have any abnormality, comorbidity, hypertension, or diabetics, or the man was in any drugs prior to the onset of this, the examination, pulmonary examinations, I will listen to the chest, and then listen to the chest, demand the heart rate, if there's any more, if there's the breathing sound, if there's good air entry, or any other abnormality that is being found in the chest. But in the absence, I like to secure the airway to see whether the man the airway is patent, the man is breathing, and there's no obstruction to the airway. Ensure that there's circulation available by setting the line with the 2 wide bore cannula, and start the infusion of crystalloid. While I was doing that, I also collect samples for urgent PCV, RBS. I also do circulations. If this demands the saturations, the oxygen saturation, if there's oxygen saturation is optimal, or to give the man oxygen at ARE, where I would be looking for other means to do, even if there's any ECG available in the ARE, I would do that, where I'm looking for to identify the risk factors. However, at that point, I will look for the drugs. If the man is breathing and the heart rate is normal, I may not need to do CPR for the man. If the saturation is still okay, or the saturation is poor, I will give the man oxygen at that point. If there's any obstruction to the airway, I will remove it, put the man on oropharyngeal airways, supraglottic airways. But if the man have lost the consciousness, the GCS at that point is less than 8/15, the man needs a standard airway, and then I will continue with the other ongoing management. I also pass the NG tube on this man to depress the gut if the man have maybe abdominal, full stomach, so that the breathing will be stable enough. For the other things I will do now depends on my finding on the investigations, because I would also like to know if the man have hypoglycemia, I will also correct the hypoglycemia. If have anemia, I will correct. If the man have hypotensions, I will also correct with what I was doing with the normal saline. And if there's maybe other like electrolyte imbalance, I also try to correct that. As I was doing this, I also need to is a multidisciplinary approach at that point, because my aim at that point is to cut the progression of the illness and then improve the clinical status of the man. Chief, the second question, I didn't get the B part of it.
As a list possible differential diagnosis. List possible differential diagnosis.
The differential diagnosis, one, it can be hypoglycemia. 2, it can be transient ischemic attack. It can also be hemorrhagic stroke. It can also be pulmonary embolism. It can also be trauma or cardiac arrest. That is the only one I can remember. Thank you.
Thank you very much, Dr. Ame, for the attempt at answering the question. Well, you tried. Let me just give my comments while after that, I will ask others to make their comments too. Well, you were not too coordinated and sequential with the rest. I mean, response to your questions. The history, I'm not sure I had that you took, I mean, history, at least from the colleagues that brought the person to your facility. Any history of seizures, any history of vomiting, any prior history of headache before the incident, any history of fall, any history of assault, drug history, so, or alcohol consumption. Then for your examination, fine, you talked about the examination, but you are not that organized. So when you attempt questions, you first do your general examination, then specific examination. The CNS, the Central Nervous System examination, you are not really detailed about your CNS. Just talk about GCS. Component of GCS, you don't know. Other things that you want to find out too. The pupils, you don't know if you checked it. You don't know if you checked the power tone reflexes. We don't know. Just talked about GCS and said it's less than 8. Want to secure the airway, fine. Then other systems too, because you need to rule out any associated blunt injury or associated injury. Then for the investigation, I didn't hear you talk about doing any radiologic investigation, especially brain CT scan. Maybe you talked about it, I didn't hear that. You said you are going to correct hypoglycemia. Fine, fantastic. So, but brain CT scan, it has to be done for this patient that is unconscious. But you want to know what is actually going on in the brain. Then you talked about multidisciplinary approach. That's fine. It's fantastic. So you need to let us know which other disciplines will be involved in management of this patient. Neurologists, the neurosurgeons, even the endocrinologists will be involved in the management. Then resuscitation, ABCD, to us to be there too. Then this patient, after intubation, are you thinking of mechanical ventilation? Do you have any plan to send this patient to ICU for further care? So all those things too should be put into consideration. Then other investigations too, specific and general investigations. Okay, talk about PCV, but at least better you do full blood count anyway, to know if there is any evidence of infection. It's a possibility. Then the differential diagnosis. Talk about hypoglycemia, TIA, PE, hemorrhagic stroke. Then the trauma, of traumatic brain injury. Anyway, then also could be maybe alcohol or drug induced too. But by and large, not a bad attempt. It was fair. Well done. Thank you. Do you have comments from other senior colleagues, please? Comments? Okay. I can't see any hand raised. I think we proceed. Is there another person interested to? I can't see any other name. Okay, 2 participants raised their hands.
Professor Shinaki is waiting, sir.
Oh, okay. Okay, Professor Shinaki, sir. You have the floor.
Yeah, thank you, Dr. Rotimi. That was a fair attempt, and the way your comment is very well noted, and if you can just adopt that format, it will be very easy to actually cover all the areas. It's not that, I'm sure it's not that it doesn't know all those things, but arranging your thoughts, getting your thoughts together is so important. And the same thing happened with the second part of the question. It was just picking and picking differentials. So if you do that in an exam, very soon you run out of ideas. So the same way you organize your thoughts for the first one, also when it comes to differentials, it's always good to be systematic as well. So systematic in terms of, are you going to start from head to toe, or are you going to go system-based? Okay. So if you do that, you find that you're able to say a lot of things from the systems or from head to toe. Okay. So it's always better to adopt that approach. With that, you can say many things, and whoever you are talking to will know that yes, you are organized, not just picking one from the head, one from the toe, and things like that. Thank you, sir.
Thank you very much, Prof, for that comment. Dr. Bashiru Isa, you have the floor, please. Yeah, do you have comments?
He's a
Dr.
candidate.
Oh, okay, he's a candidate. Oh, okay, fine. Okay, thank you. So, Dr. Bashiru Isa, what number, please? From 1 to 20. 2 has been taken.
Question 1, sir.
Okay, question 1. We have a primary gravida with prolonged labor that is scheduled for emergency cesarean section due to fetal distress. A primary gravida with prolonged labor scheduled for emergency cesarean section due to fetal distress. A, outline your management, your anesthetic management, 15 marks. Then B, what are the possible methods of post-op pain management? A, outline your anesthetic management, 15 marks. Then what are the possible methods of post-op pain management, 10 marks? Your time starts now.
Okay, thank you, sir. So I would like to start dividing the anesthetic management into pre-op, intra-op, and post-operative management. So pre-operatively, this patient is a primary gravida who presented with obstructed labor, so which is an emergency situation with associated fetal distress. First of all, I will do ABC of resuscitation. This patient might be dehydrated, and this patient might be pale. Then I will assess the possibility of patient having pallo. Then I will also optimize as much as possible. And this patient might be hypoxic at the same time, so I will quickly place her on oxygen supplementation in order to also improve the oxygen supply to the fetus as and cross-match. I will outline my plans. First of all, I will obtain informed consent because it's an emergency situation. I will obtain informed consent, and after informing counsel the patient for the possibility of the technique I'm likely going to employ. So it depends on my pre-op assessment. This patient, if she's fully conscious and awake, so I would like to go with some arachnoid block. So I would like to explain to her the technique, and then she will now consent for that technique. Then I'll quickly group and cross-match 2 units of blood. Then I will then hello.
Hello, since we've lost you, we can't hear you.
We can't hear him.
We can hear you, Dr.
Hello.
Bashir.
Hello.
Yes, go ahead. Continue.
Okay, sir. Am I audible, sir?
Yeah, you're audible, but we lost you
transiently. All right, sorry, maybe it's
yes.
network issue. So I was trying to outline my plans before the procedure. Then I will now inform the theater people about the procedure. Then I will prepare this patient. And then intraoperatively, I will quickly do my cockpit drill to check my anesthetic machine, then my oxygen supply. Then I would also like to check my suction machine. It is functioning and is within reach. Then I will now prepare, though my initial plan was subarachnoid block as a technique, but I will also prepare for possibility equipment as well as the airway aids like the ETC, the appropriate size ETT, at least two, 0.5 above and 0.5 below the appropriate size. Then my airway is the bougie, the stillate, the Magill fossil. Then I will set the subarachnoid blocks, set the spinal needles, my heavy machine, then my spinal pack. Then after that, when patient
4 minutes gone, please. You have 2 minutes left.
Okay, so
you have 2 minutes left.
Okay, thank you. So intraoperatively, I will quickly attach monitors to this patient to take my baseline monitors, the non-invasive blood pressure, the pulse oximetry, the temperature, and then the block. I would like to preload this patient with at least 1 liter of normal saline. Then after the preload, I will now go ahead with my procedure. The subarachnoid block first, I will now locate the place where I'm going to give my subarachnoid block. Then after that, I will now give my subarachnoid block. Then I will quickly ask the patient to lie down. Then I will place her on a left lateral stitch to prevent aortocaval compression. Then intraoperatively, I will monitor the IV fluid I'm giving her. Then I will pass catheter at the same time, monitor the urine output. Then I will be monitoring the vitals intraoperatively. Then as well, I would now like to give the patient oxygen to supplement for the fetal distress. So I will give the cesarean section. After that, immediately I will now withdraw my oxytocin levels kept. Then I'll also, before I even give the spine, I will have withdrawn my ephedrine level and kept in case of
minutes gone.
All right. Hello, ma'am. Then after the delivery of the fetus and the...
You've exhausted your 6 minutes, please.
5 international units of oxytocin. Then I'll also put 20 international units of oxytocin in normal saline run over.
Okay. Thank you very much, Dr. Bashiru Issa. Thanks for the attempt.
Yes, sir.
Hello, can you hear me?
Yes, sir.
Yes, I said your time is up. So okay, thank you for the attempt. What I would like to say is this: you should be able to learn how to manage your time very well. You understand? So
okay, sir.
We're given 6 minutes, and there are 2 questions: the A aspect and the B aspect. So you didn't even attempt the second aspect. So, and the A aspect is 15 marks, the B aspect 10 marks. So you did not, so you went to town in quote with the first aspect 15 marks, and you can't get the whole 15 marks. 15. So,
Yes, sir.
so when you get to exam, irrespective, irrespective of the aspect of the exam, it's orals, if it's OSCE, if it's even the written, you must be able to manage your time very well. So the allotted time, you must manage it very well. And usually it's close marking. So we said the question, first one says, outline your anesthetic management. So again, the arrangement you need to be more coordinated and coherent, and it should flow. It should flow.
Yes, sir.
Then must be able to, as an anesthetist, you must be able to be specific. You can't say you place, say the place where you put your block. You have to be specific. What landmark do you want to use? The doses of the agent you want to use, the dose of the agent you want to use, and so on. So you need to be more specific, and you go straight to the point, please. Then the second aspect was not attempted. It says, what are the possible methods of post-op pain management? So you didn't even get to that point. Well, yes, I want to throw the, do we have comments from other senior colleagues, please?
There is a hand with iPhone.
Yeah, the iPhone, I wouldn't know if
name
the
our
person...
devices.
The person with iPhone, are you a candidate or you want to make comments? Hello?
Hello, sir. Good evening, sir.
Yeah, good
Sir,
evening.
I'm a candidate, sir.
Sorry, what's the name, please?
Sadiq Ahmad
Sadiq.
from FTH Kasina.
Okay, fine. So what question do you want to pick from 1 to 20? Questions 1 and 2 have been picked.
Okay, sir. So I will pick question 8, sir.
Question what?
8.
8. Okay.
Yes, sir.
Okay. An 8-year-old is scheduled for adenotonsillectomy. You have an 8-year-old scheduled for adenotonsillectomy. Discuss your pre-op management. That's A part. And B, discuss the post-op pain management. A part, discuss your pre-op management, and B, describe your post-op management. Your time starts now.
Okay, sir. We start for the 8-year-old boy who was scheduled for adenotonsillectomy. His pre-op management will entail the history, the examination, the review of the investigation, and also the preparation for the surgery. For the history, the history of rhinorrhea and the history of a recurrent fever, and also the recent history of upper respiratory tract infections. Also, sir, the history that may suggest obstructive OSA, the obstructive sleep apnea, will also be valued here. And also the history of congenital anomaly, history of any congenital and history of recurrent hospital admission will be important. Also, sir, history, history of recurrent blood transfusion or any bleeding disorder that is that has run into the family will be important in the history. Then other anesthetic and also other medical history will be important. For the examination, the examination of the airway is important so that to detect any features of a difficult airway in the cell, such as also peshi that may suggest other congenital anomalies, such as such features that may suggest difficult airway may entail the regressive mandible, small mandible, microglossia, short neck, and also other features. Then also for the investigation, I would like to know his full blood count, looking for the white blood cell for recent infection, and also I will look for the hemoglobin, looking for anemia, and also I will look for the platelet, looking for thrombocytopenia or thrombocytopenia, and that may cause a risk of bleeding. And also, so I will also look to his clotting profile, which may show me whether the patient has risk of bleeding or not, which may tell the PTTK and also the INR. And also for the examination, for the investigation, the other investigation depending on the history and examination will be entitled. Then for the patient preparation, patient will be counseled and also informed consent will be obtained, and also patient will be placed on nil files according to the NPO guidelines. Then blood will be group and safe, at least 1 pint of blood, and also the theater team will be informed, and also seniors will also be informed as case of difficulty. That's for the my pre-operative preparation. For the sorry sir, I will also place the patient on the IV fluid to maintain his maintenance, and also for fluid management. For the first of pen management, this patient is likely the common complication that they have. They are likely to have OSA, which so I will try to avoid opioids or to use a fast acting opioid, and also to use the fast acting opioid. So multimodal anesthesia will be a very important choice here, where we will use the different drugs with different mechanism of action, and we will use the low possible dose for those drugs so that to get the maximum effect. Also, we can use the nerve blocks. We can block the nerves in the mouth. We can block the superior-laryngeal nerve, and also we can block other nerves in order to provide the adequate anesthesia. Also, the patient may benefit from PCA, patient control anesthesia, where the fast acting opioid was less respiratory deprivation will also be entitled. But I will not use the NSA as this may include bleeding during the multimodal anesthesia. Also, this patient may also benefit from psychological management. That's a non-pharmacological management may help in
Minutes
management
exhausted.
of this patient. Yes, ma. Hello, ma.
6 minutes gone, please.
Okay, ma. Thank you.
Okay, thank you very much. That was a fair attempt. Do we have comments from other consultants or senior colleagues, please?
Good afternoon, Dr. Rotimi. May I speak?
Yes, go ahead, Prof. Ma. Good afternoon.
Good afternoon. Yes, well done, Dr. Issa. One thing I notice is that you're a bit vague in some of the things you say. When you can score extra 0.1 marks here and there. You're looking for medical disease. You didn't say the ones that you're going to look for. Sickle cell, asthma, things like that. Then you say fasting guidelines. You didn't say what you were going to. It's a bit vague in those places. You got to multimodal analgesia. You didn't say what you were going to use. So you're assuming that probably the examiner or the person that's marking the script would know. So try to be focused on those important things and give one or two examples. Don't just leave it vague like that, so that we know that you understand the topic and understand the child. Also, don't forget that in children, there's always some form of distraction that you are going to give at the preoperative section, either explanation or showing them the equipment and stuff. Always try to put in how you are going to psychologically prepare children. Okay? And please don't forget loose teeth.
Okay.
Thank you.
Thank you.
Thank you, Prof. Ma, for those valid comments. Do we have other comments? Comments from other consultants or senior colleagues, please?
So please, can I add to what has been said already?
Yes, please, go ahead.
Okay, I don't think I heard them talk about separation anxiety. This is the age was 6 years old, or it's how he's going to manage that. A 6-year-old child, how is going to manage separation anxiety. I think he missed that part.
Okay, ma'am. Thank you, ma'am.
Thank you very much. Any other comments, please? Okay, Prof. Oshinaike.
Yeah, thank you. It's just important to say that I love the way it started. Okay. It started with a summary of what he was going to do, and he started picking them one after the other. So I think that was a plus for him. So you should also note all those important points that has been raised. Thank you.
Thank you very much, sir, for your comment. Okay, so do we have another candidate that's interested? Kindly indicate by raising your electronic hand, please. Any other candidates? Okay, if you are not raising your hand, let me just, okay. Thank you. Dr. Nonso Okeke, kindly unmute and pick the number from 1 to 20. Dr. Okeke, please unmute and talk, please. Dr. Nonso Okeke. Okay, do we have another person? Do we have Dr. Anoluapo Ayegoro here? What of Dr. Charles Nombagu. Dr. Charles Nombagu. This is an opportunity for you guys to talk and for senior colleagues to make inputs. It's not when you get to exam hall that you now be confused. Hello? Who is that, please?
Hello?
Yes, we can hear you.
Hello?
Okay, Dr. Nonso, right? Okay.
Yes, sir. Good evening, sir. Good evening, seniors.
Yes. We'll be waiting for you. What happened? Okay.
Sorry, my network was a bit fluctuating. Sorry, sir.
Okay, no problems. So kindly pick one question, one number, one question between 1 to 20.
Number 5.
Number 5. Okay, good. List factors that contribute to post-operative nausea and vomiting. List factors that contribute to post-operative nausea and vomiting. That's 10 marks. B aspect says, what drugs are available for the management? What drugs are available for the management? 15 marks. Your time starts now. Dr. Keke. Can you all hear me, please?
Yes, sir, we can hear you, sir.
Dr. Nonso Keke.
Hello? Sorry, my network has been fluctuating. Sorry. Hello?
Just look for a location that will be a bit stable for your network. You have just 6 minutes. Quickly attempt the question, please. Thank you. Did you hear the question? Hello?
It's in the chat box.
Hello?
Okay, fine. The question is in the chat box.
Hello? Okay, sir.
We're waiting for you.
Hello, it said list factors that contribute to nausea and vomiting, sir.
Not just nausea and vomiting. Post-operative nausea and vomiting.
Okay, sir. The nausea and vomiting is one of the challenges that anesthetists face post-operatively. It can be quite challenging both to the anesthetist patients, and most patients are not very comfortable when they have nausea and vomiting. Nausea and vomiting poses a challenge to the anesthetist, but there are factors that could be associated to nausea and vomiting. Those factors are it could be from drugs the patient is given, from pre-op. Some patients are on some medication that could impact, cause post-op nausea and vomiting. Intraoperative medication like opioids could affect nausea and vomiting. Then the preparation of the patient that came in that is not preoperatively, that is not well fasted, could also be a cause of preoperative full stomach. Emergency cases that the fasting is not well established. It could also be a cause of trauma case. Patients that came to us emergency could also be a cause of preoperative, post-operative nausea and vomiting. Patients that come with a full stomach patients could also affect nausea and vomiting. I mentioned medications, opioids, even especially the long-acting one towards the end of the procedure could affect nausea and post-operative nausea and vomiting. When you do general anesthesia, it's also a risk factor to when compared to when you do general anesthesia, when compared to regional anesthesia, it could affect the nausea and can be a factor that will prevent the patient to nausea and vomiting. Some patients has a history of motion sickness, which also be a trigger to nausea.
4 minutes gone.
Hello.
Yeah, we can hear you. Please continue. You have less than 2 minutes.
Hello. Hello.
We can hear you. We can hear you, Doctor.
We can hear you. Please go on. Please.
Please continue.
Hello.
Continue, please. I think he has dropped off. Okay, so we just wait for a few seconds, max a minute, to allow him to join us. Okay, can we have another candidate, please? So that when he joins, then he can round off, then we take comments. Any other candidate, please? We have Dr. Isioma here. Isioma Rumade. Do you have Dr. Onipe Peter here?
Good evening, my teacher. I think we have we have Dr. Peter Onipe here. We have Dr. Godwin Adaja, and then we have leader Joshua and Gogori and Emmanuel. All of them are here.
Okay, they should indicate by raising their hand. Dr. Keke, you are back. So kindly round off so that we can take comment. Okay. Dr. Nipe.
Yes, sir.
Please unmute and take a number, please.
Number 10. Thank you.
Number 10. Okay. Okay, number 10. What is BMI and how is it calculated? What is BMI and how is it calculated? That's A part. Describe the anesthetic consideration in a morbidly obese patient for laparotomy. Describe the anesthetic consideration in a morbidly obese patient for laparotomy. Your time starts now.
Okay. Obesity is a multi-systemic disease that affects obesity is a multi-systemic disease that is common among the patient coming for surgery, especially in Western world. BMI is one of the score, or is one of the criteria from assessing the level of obesity of a patient or of an individual. It is calculated by dividing the mass of a person, dividing the weight of a person in kilogram by the height square, and the unit is kilogram per meter square. The anesthesia for patient coming for an obese patient coming for laparotomy. Sir, is that the second question, sir?
Describe the anesthetic considerations in a morbidly obese patient for laparotomy.
Okay. A morbidly obese patient is a patient whose BMI is 40 and above. The obesity, as I've said earlier, it affects the whole system, starting from airway, because this patient may be at risk of difficulty airway because of the fat that has been added in the airway. This patient is also at risk of obstructive sleep apnea. The patient is also at risk of, for the cardiovascular system, this patient could also be hypertensive. It also have other cardiomyopathy. This patient could also be having ischemic heart disease. For the respiratory system, this is a patient that can easily desaturated intraoperatively. So and so this patient is a patient that should be pre-oxygenated before induction of anesthesia. And for the gastrointestinal system, they are always at full stomach because they have a delayed gastric emptying, and so this patient should have acid prophylaxis preoperatively. And they are also at risk of DVT. So preoperatively, they should be the prophylaxis for DVT should be commenced, both pre-op, intra-op, and post-op. This patient is also there are also challenges in locating in moving these patients because of their weight. You have to get more people to help in moving the patient, and also there is also challenge in locating landmark. Locating landmark, setting line for them is also challenging.
Four minutes gone, please.
Okay.
Hello.
Yes, sir.
Are you done?
No, I'm not done. Pharmacologically, intra-op, if the surgery is going to be general anesthesia because the patient will be airway has to be secured. So the induction agents should be drugs that are less lipophilic, and the drug dosage should be based on ideal weight. And so for the subsamethonium, the induction it will base on the dosage will be based on the real weight. While the other medication, the other drug that will be given intraoperatively will be based on ideal body weight. Intraoperatively, there is also challenge in calculating the transfusion trigger for this patient because we have to use ideal weight of the patient in calculating the transfusion trigger, and also the intra-op fluid management will also be challenging because ideal weight also has to be used. I'm done, sir.
Okay, thank you very much. That was a fair attempt. Let me just quickly give my comment. I expected you to give us the range for normal values for BMI. You talked about, you got the definition or how it's calculated. But I expected you to give us the range, saying that was the normal range for the patient with normal BMI, the underweight, overweight, and obese when patient is obese. So what is the cutoff BMI? And also when patient is morbidly obese, what is the cutoff mark? So you should have mentioned that. That's one. Then two, when you're talking about the anesthetic considerations, you were sequential in such a way, but you need to be more coordinated. Airway, cardiovascular, respiratory, and GI, you mentioned it, but you didn't put more energy on them, especially the respiratory system. I was expecting the fact that they have increased oxygen consumption because of the metabolically active adipose tissues they have, leading to increased CO2 production. I was expecting to hear functional residual capacity that is reduced, and that will encroach into the closing capacity. So predisposing them to desaturation. You talked about desaturation, but at least you should have put more energy. Then pulmonary compliance is reduced, and also there's risk of BQ mismatch too. You should have said that. You talked about IV, you said IV line. You have put emphasis, let it stand out. IV access is a major consideration. That is very important. Then equipment, you should have appropriate equipment. The table, operating table. So that too is very, very important. Some you have to combine operating tables. And some you must have the one that can carry that weight. Some tables, they have maximum weight that you can put on them. So that's very important. Then monitoring, times it could be challenging, especially non-invasive blood pressure monitoring. And also, especially when you have patients with conical shaped arms that your cuff cannot go around. Some of them you have to do invasive blood pressure monitoring for them. So these are the challenges in addition to what you talked about. Thank you. Any other comments from senior colleagues and trainers, please?
Hello, Dr. Rotimi. Sorry, it's me again. Just a quick comment. Let's not forget that all these patients are coming for surgery. So there should be a surgical aspect in your answers. This last doctor, yeah, you talked about a lot of things, you have a lot of information, so that's good. The person that attempted the question on post-operative nausea and vomiting, patients, anesthetic, then surgery. What's the surgery contribute to post-operative nausea and vomiting? Morbidly obese, what's the problem with surgery? It is technically difficult. So always try and remember whether there's a surgical contribution to your answer or not. Think about it when you're doing your anesthetic considerations or any answer. What is the surgical, how does this scenario affect the surgery, or how does the surgery affect my scenario? Always try to include something on the surgical aspect. Thank you.
Thank you very much. Do you have other comments? Dr. Okeke, let's tidy up your question. Are you there? Dr. Okeke, yes, can you hear me?
Hello, sir.
Yes.
Yes,
so
I'm
your
hearing
question,
you
okay, you can hear me now. Fine. Your question says post-operative nausea and vomiting. I expected you to have divided it into the patient, surgery, and the anesthetic consideration or factors. Do you understand? So the risk factors for the patient, talked about it. For the surgery, talked about it. So there are some surgical procedures that they have high incidence, or they are treated with high incidence of post-operative nausea and vomiting. So you should be able to highlight those aspects. Ophthalmic surgery, especially strabismus surgery, breast surgery, and so on, ENT. So you talked about anesthetic stuff. You kept on saying drugs, opioids, went back to that. But there are other things too. Talk about GA, that is fine. Intravenous drugs like sotaltentone, etomidate, and ketamine. So they, are part of the factors that contribute to post-operative nausea and vomiting. Then the use of nitrous oxide too, and also if the patient is dehydrated. So for the patient, you mentioned some, but you should have divided them and exhaust all the factors under each subheading, like female, previous history of PNV, motion sickness, which you talked about, then non-smokers, and use of opioids. So if you have that, then you talked about, then the second aspect you don't even mention at all. What drugs are available for the management? It was not touched at all. So you can divide that into 5 groups. So because you look at the pathophysiology of PNV, so there are 2 receptors that are affected. So and these include muscarinic receptors, the dopaminergic receptors, serotoninergic receptors, histamine, and neurokinin. So you have drugs that can block all these things. So anticholinergic can have iosine, antihistamine can have cyclizine, then dopaminergic antagonist, droperidol, metoclopramide, serotonin antagonist under citron and co. Then steroids, you have dexamethasone. So that will, at least when it is well packaged like that, you are well guided, and also it will help the examiner too. Okay, thank you very much. Can we take the last question for today? Who wants to take the last question? Any candidate available for that? Dr. Adaja. Okay, Dr. Joseph Ezeogene. Please unmute and you can ask your question or take the number.
All right, sir. Good afternoon, sir.
Yes, afternoon. So what number, please?
Okay, give me number 6.
Number 6. Hey. You have a 32-year-old lady scheduled for laparoscopic cholecystectomy. A 32-year-old lady scheduled for laparoscopic cholecystectomy. A, describe your pre-operative management. 10 marks. B, discuss
Come again, sir.
Sorry? B, discuss possible intra-op events and management. I will take it again. Listen, please. Can you hear me? Hello? We have a 32-year-old
I can't hear you.
A 32-year-old lady that is scheduled for laparoscopic cholecystectomy. A, describe your pre-op management. 10 marks. B, discuss possible intraoperative events and management, 15 marks. Did you get it? Hello? Dr. Joseph.
I didn't get you, sir.
The question is in the chat box, please. Read and respond to the question, please.
Hello?
Yes.
I couldn't get you, sir. Network was.
Please check the chat box. Check the chat box. The question is there. Read and attempt the question, please.
Hello?
Hello?
Hello? Okay, let me get it from the chat.
Yes, that was what I said.
Okay, sir.
Your time is already done. Have you seen it?
Hello?
Can you please attempt this question?
Okay, I've seen it. Okay.
Yes, please.
Okay, but I should discuss discuss the pre-operative management. One, I will take a brief. I will take her examination.
Because of Ramadan break, that's why.
I'll do full blood counts. I'll do liver function tests, coagulation studies, and baseline.
Continue.
And a baseline ultrasound scan, abdominal ultrasound scan, past medical issues, diabetic or hypertensive. We strive on. We placed this. This patient will be advised on a apply some pre-operative fasting procedure to be done. He explained to the patient, will be explained. It's going to be general anesthesia, considering the fact there is a laparoscopy surgery and for the surgery. And the second part of the question says, discuss intraoperatively. The procedure is a procedure that they're going to use a laparoscopy, a pneumo peritoneum. So inflate the abdomen. So this patient is likely going to come down with pneumoperitoneum from the abdominal, raise the intra-abdominal pressure.
4 minutes gone, please.
That can hinder the hello? Okay. Okay, event can lead to reduced cardiovascular cardiac output, renal pressure can also bring about, can also cause acute kidney injury in these patients. So those will be watched out for. There's we ensure that the maximum millimeters of 15 centimeters of water intraoperatively. It is also at risk of cardiovascular events like arrhythmias. It should be top notch in this patient. And there's also chances of hemorrhage during this due to additions, or if the bladder is inflamed, then achieve with use of diatemy.
Six minutes up, please.
Okay, basically, then, thank you.
Thank you very much, Dr. Joseph. I couldn't really hear most of the things you said anyway. The network at your end was very, very unstable. So it's a bit difficult for me to make comments because I couldn't hear most of what you said.
Hello?
Hello? Yes. Anything?
Hello? Can I be
Yes, hello. Your time is up. You don't have, your time is up, please. Your time is up. Thank you very much. Well, what I just have to say is hello. Dr. Joseph, your time is off. Kindly just mute your device. So we have a patient going for laparoscopic cholecystectomy. They describe your preoperative management. I was shocked when you started. I was just hearing some investigations. I was wondering why you decided to start with investigations. Anyway, so, and maybe it was network. Maybe you talked about history. So you need to take adequate history, the 5 Fs, though it's not every time that you find that, but is a guide. So female, 40, fair, fat, and fertile. So you have that 5 Fs, and you take adequate history, then physical examination, then investigation, you optimize this patient for surgery. Then intra-op, because the laparoscopic surgery, so there will be insufflation of CO2. So insufflation of CO2 is done to aid visibility anyway. And the idea is to push the abdominal content away from the anterior abdominal wall so that they can have access and see what they are doing. So, and it's use CO2 because it does not support combustion. So diatemy, laser can be used concurrently. And this insufflation should be at a rate of 4 to 6 liters per minute. And the pressure should be between 10 to 15 liters of mercury. So the pressure should not be too much. And also ongoing, you can have maintenance flow of 200 to 400 liters per minute. And intra-op, you need to watch out for some things because of this insufflation of CO2. Respiratory system, you need to watch out for increased airway pressure, and maybe reduced functional residual capacity, pulmonary compliance will be reduced, and increased VQ mismatch. And also it depends on the positioning. Sometimes they used to say, do Trendelenburg, do reverse Trendelenburg, depending on which aspect of abdomen they're working on. So, but for this laparoscopic cholecystectomy, definitely they're working on the upper part. So you need to factor that in. For the cardiovascular system, because of that increase in intra-abdominal pressure, may have reduced venous return, and that may affect your blood pressure, the cardiac output and blood pressure. There may be increased systemic vascular resistance, and also there could be risk of arrhythmias. Then for the GI, you have regurgitation and so on. So the positioning too, for some laparoscopic procedures, which you may have to do head down, that's reverse Trendelenburg, there may be inadvertent migration of the endotracheal tube to one of the bronchi. So you may have endobronchial intubation. So you need to watch out for this, and you attend to it accordingly. The effect intra-op, you need to watch out. The distension too can cause vagal stimulation. So watch out for bradycardia. And like I said, the blood pressure, you need to anticipate all this and manage it. And I hope also be sympathetic stimulation to watch out for that too. Absorption of CO2, need to watch out. So intra-op monitoring of EtCO2, very, very important. So capnography in the management or monitoring of patient going for any laparoscopic procedure is crucial, very, very important. Also, you monitor the airway pressure in addition to other things you need to watch out for. Our time is fast spent. Thank you very much, everyone. So I hand over to Dr. Nsese. Thank you.
Thank you very much, our facilitator, for handling that session for us, Dr. Muyiwa Rotimi. Please, you take a little time to recognize the presence of our very senior colleagues in our midst. And we welcome them to say one or two things before I hand over to the president. We have in our midst Professor Ronke Desalu. We have Professor Bibi Osinaike. We have Professor Elizabeth Obolingwaso, Dr. Aderonke Adesinya, and Professor Henry Embu. Please, you are all recognized and we welcome your contributions. Thank you very much. Yes, ma, please.
Hello, good evening.
Good evening,
Hello,
ma.
good
Please,
evening, everyone. Hello, good evening. Can you hear?
Good evening,
Good
ma.
evening.
We can hear
You're
you, ma.
welcome, Madam IPP. Welcome.
Welcome.
You have the floor.
Well
please.
done. Good evening. Thank you so much, Madam President. I want to salute our facilitator for the day, Dr. Rotimi Muyiwa. I want to salute the moderator, Dr. Nsese Ideme. Also, all the participants, that is the candidates that came up. It was a very bold step for them to have joined the meeting. I appreciate all the speakers, the candidates, that is. Many of them did very well. Most of them did very well. And the comments by the colleagues is well appreciated, that the guidance for them. I think they should please take note of them and take it to heart to apply all those corrections, especially as these are geared towards having a good outcome in the exams. I want to just ask that trainers should please work with candidates to help them to be practicing some of these things better, to talk in exam condition, because it will improve their performance to improve their diction. Please, I want to ask that people pay attention to their English, their vocabulary, and the way they deliver the whatever the message they have. They should come across in a very clear and articulate manner. Just on a general note. Thank everybody for this session. It's very good. I wish we had started earlier, but I think better late than not. And thank everybody. And thanks for the opportunity to make a comment. I also asked the first participant, I don't know his name, but I asked him to DM me. There was something I wanted to tell him privately, but I couldn't remember his name. I'm sorry about that. Thank you so much.
Thank you very much, Ma. Professor Osinaike, please, you have the floor.
Okay, good evening, everyone. This is actually a very great program. Just as Professor Nwaso said, is this something we should have started? I think 2 or 3 sessions of this will have been so good for many of these candidates, because it's better to fumble here than go to the exam and fumble. So I want to say for those that took part in this session, I want to say congratulations to you, because you now know what it's going to be like, either for your written or for your Viva session. So use this opportunity to better prepare for the exam. And also for those who did not take part, at least you listen to what was said. One thing we should know about this exam is that most of those stuffs are things you do every time. I'm sure you know. But when you come to the exam, there are things we expect you to say. There are ways we expect you to say some things. There are some things we want to hear that you must say when it comes to, imagine that question on nausea and vomiting. There's no way you answer such a question without telling me about those surgical conditions that will predispose to nausea and vomiting. If you've not said that, you have not said anything. Okay, so there are some things you must say. And that's why preparation for exam is very important. So it's not just enough for you to do the anesthesia, but you must be able to communicate to your examiner what you do and how it's supposed to be done properly. So I must say it's a very good one. And thank you, Dr. Rotimi, for that coordination. It was great. And thank you, the NSA, Dr. Mohammed, and everybody, and the president. Thank you for the opportunity. Thank you all.
Thank you very much, sir. Please, the floor is still open to our senior colleagues on the platform. Thank you.
Yes, and perhaps we may have any of the junior ones that wants to ask a quick question. Dr. Adeshi, your president, Society of Specialists in Airway Management, please can you make a comment? Dr. Embu, are you still on board? We appreciate you. Do you have anything to say? Okay, Dr. Embu is gone. Dr. Adeshio, yes, you have the floor, Dr. Adeshio.
Thank you very much, Ma. I hope you can hear me clearly.
Yes, we can.
Okay, thank you very much, Madam President, the ESCOs, and the Education Committee for this well-packaged case presentation, case-based discussion. So I just want to encourage all the residents and trainees that don't ever be afraid of expressing yourself. There is hardly anything they're going to ask you in exams that you will not at least know between 30 to 50% of what is expected of you. So the most important thing is to, like all our professors have said, learn to express yourself accurately, correctly, and confidently. Even if you don't know a question, just relax and compose yourself and give a very, how do I put it, intelligent answer. Don't make yourself look like somebody who doesn't know what he or she is doing. So if you have that attitude, it will really help you in answering questions in exams. Secondly, always discuss with your colleagues. Before you do a case, during the case, and after the case. This was how we were taught during residency. You read before you go and see your patient. You read before you start the case. Then intra-op, if there's anything you've been asked or any aspect of that case that you don't understand, you're so lucky these days, it's just a click away. Click on it and Google it and learn there and there, because you really might not have any other time to discuss that particular situation. And that was my experience during residency. Anything I saw during our practice or cases or whatever in ICU, I would just read it there and there. And most times I would see it in exams. So that is my encouragement to you. And I believe that you will do well if you apply all this advice that all our senior colleagues have given you. Thank you very much.
Thank you very much, Dr. Adesina. Please, I hand over officially to the president. Thank you for the opportunity.
Yes, thank you very much. I want to sincerely thank everyone that has made out time to be with us here today. And I want to say it can only get better. We have taken all the comments and the observations. I want to say that we will put it into consideration to do more CBD sessions. But let me say this, that we sincerely want to thank the facilitator, like other speakers have said, and the moderator, especially the moderator was called upon just yesterday, and she was ready to swing it into action. We find a little bit of a challenge getting our members to come in and assist us with moderation. So we are eternally grateful to you, Dr. Nsese, for bailing us out. And of course, Dr. Rotimi, yes, you are very professional about this facilitation. We are grateful to you. Now, to my own chair, thank you so much, Professor Deti, for your doggedness to ensure this thing works, and the entire education team. Dr. Oshole, we appreciate you. And to all, Professor Desalu has exited, but you see, she had a lot of contribution to make, which others have reiterated, Professor Soshinaike and Obolinwaso. Let me summarize it by just saying this to you candidates. Please approach your questions logically and sensibly. Put in mind that most questions will have the pre, the intra, and the post considerations. So everything starts from pre-op. So approach all your questions by dealing with it from pre-operative considerations. The other side of it is that most questions will have the anesthetic, the surgical, and the patient factors. At least those three. So when you tidy up your presentation in what I call packaging, you know, that word packaging now is going about in many sectors, you know, even in the social world. So when you package your answers very well and you go orderly, then you can never miss it. So we want to wish you all the best. We want to pray that you continue to build up on these templates we have given you, and we wish you the best indeed. You are bold. Yes, that was a good step, like one of the speakers said, to come up and face. In fact, this one is not just an exam, it is the whole of Nigeria and aesthetics. So you are bold and you did fairly well. So please go in this strength and consolidate yourself, build up on it. You can make it. So I'll be calling on the PRO to give us some information. But before then, the chairman and education committee wants to give us a word. And also, I believe he also wants to tell us about our plan for the upcoming national, because this one is targeted for West Africa. So we're going to have a session just after West Africa towards the national exam. But above all, Professor Shinaki, we have taken your observation. We will do more CBDs, not waiting until the exam is here. Thank you. Professor Deti, over to you, please.
Thank you very much, and apologies for my voice. This is the best I could get today. I'm getting better, so no worries. You said it, or what I wanted to say, that there will be another webinar, case-based discussion on Saturday, 20th, targeting those who have registered for national. And we'll make it an extended version. We'll try to get 3 or 4 facilitators so we can add 30 minutes to it and enjoy ourselves. The other thing I want to apologize is that we actually planned for at least 4 of these webinars. Something just did not click. So we managed to have one, and it is a very impactful one. The introduction of this picking numbers by Dr. Rotimi is noted, and we will incorporate it henceforth because it seems to be more effective. So we will adopt that. And to the resident rep, please liaise with me properly, because before in the coming weeks or after the college exams, you should plan to be having tutorials on your own. This platform, the NSA platform, can be made available to you for discussion. Then you can ask 1 or 2 trainers to be with you to hear your discussion. So we can plan for that. So you can have as many as you can while we organize this CBD periodically for your benefit. Thank you very much, Madam President.
Thank you, my education chair, Professor Deti. PR, over to you briefly, please. Thank you.
Thank you, Madam President. Good evening once again, my teachers and trainers, and thank you for being part of this webinar today. To intimate us about our upcoming events, we have the All-African Anesthesia Conference coming up in South Africa in September 2024, and our AGM and Scientific Conference, NSA, will be coming up in Enugu City in November 2024. Please kindly note that the webinar's recording will be made available on our YouTube channel as soon as we finish this presentation. Thank you all. God bless you.
So thank you, everyone. We'll see you on 20th. And please watch out for information on the webinar through your resident representative, that's Dr. Shaibu. Thank you very much.
Thank you, sir.
Good evening.
Thank you. Good evening. Thank you, Dr. Deti. Sorry, please.